Good afternoon. I'm getting talked to here. Let's make this go away there. So I was thinking maybe since we only have one person, maybe we will kind of go through the presentation and then at the end have some time to really just talk about what's going on and how we can be most helpful. You can advance, Alana. So I have some slides here just to help kind of guide this discussion. And I thought we might want to start off with the idea of distress in cancer, because that term gets thrown around a lot now. And I find a lot of people don't actually know what it means. But you may have seen this screening tool we have that's on the computer here, which is called our distress thermometer. And we use it here at Taussig, and most cancer centers around the country are actually using this same tool to help see if people have things that are distressing going on in their lives that we might be able to help. And when we think about mental health, when we talk about distress, we're talking about things like sadness, irritability, worry, fear, anger, sometimes one of those, sometimes a combination, maybe even all of them at the exact same time. Next. So there's some kind of big topics on here that I wanted to make sure that we talk about. When we talk about distress, there's key points that it's actually incredibly common, that it has lots of causes. It's sometimes normal to be distressed, to have a response to something stressful, but it's also sometimes not normal. It can be very impairing. It can impact those around us, maybe our loved ones or our providers or our friends or family. And it's incredibly important that we address this, which is actually something that's relatively new in the cancer care world, thinking about how we manage people's emotional distress. Next. So when I say it's common, distress in cancer probably impacts more people than not. We don't have great data on that as a big topic, but what we do know is probably 25% of people with cancer actually meet criteria for a depression disorder that a doctor would kind of label them with. And 25% of people also meet criteria for an anxiety disorder. Those don't necessarily overlap. So when we think about, there's 19 million people in America who have had cancer, that's a huge part of our population. So this is incredibly, incredibly common. And it's also common in caregivers. Those of us who are taking care of people who have cancer also have distress commonly. And it's predictable for a lot of people. We know when distress tends to be highest and when it tends to get better. So you may notice that distress is highest right after diagnosis, especially that first month, or during times when our treatment is changing, when we are going from one thing to another, or we're finishing something. Or maybe when our scans or our labs are coming up. You may have even heard people use that term scanxiety, right? Scan anxiety. Or even when we're completing treatment, people can have higher levels of distress. And that's a surprising one for some people, that we get through treatment and then all of a sudden we're having more stress than we have before. And that's actually really common and predictable. Next. Distress in cancer is also caused by lots and lots of things, right? So it's not as simple as we fix one problem and then we're good. There's usually lots of things that we can work on to try and help people do better. So when we talk about mental health symptoms in particular, we talk about the fact that cancer itself can actually cause things like depression and anxiety. There's really interesting research being done now looking at things like how inflammation probably is a big cause of depression and anxiety. Even healthy people with depression and anxiety have higher levels of these little tiny chemicals in their brains that are linked to inflammation. And what else causes inflammation in that those little chemicals go to our brains? Well, cancer does. And we know that the kinds of cancer with the most inflammation have the highest rates of depression and anxiety. So we're not talking about things like people who just failed to cope with something stressful or weren't strong enough to get through this. There's real, on a cellular level, reasons that people with cancer struggle more with their mental health. We also know that cancer treatments can cause mental health symptoms. So things like chemotherapy, immunotherapy, endocrine therapy, radiation, surgery, all of those things have been linked to higher rates of depression and anxiety from a variety of different kind of pathways that cause that. And we know that other medical problems that come up with cancer, so maybe we're on a treatment that causes some of our electrolytes to get really funny. That may be partly why our mental health gets worse. Or we might just have other medical problems like our thyroid doesn't work well or something. And all of those things can cause people to have mental health symptoms. I mentioned that sometimes distress is normal, right? Having emotions as a response to something really stressful is appropriate. And I always joke in my clinic when people apologize for crying that, you know, you're just as likely to get referred to me for not showing enough emotion as you are for showing too much. But sometimes if our emotions start to become impairing, they start to make it hard for us to do the things we need to do in our daily lives or participate in our treatments, then they really need to be addressed and treated. So I put an example up here because I think that this helps for folks to understand as a physician how I might think about something like depression, you know, where depression is a term that gets thrown around a lot. But depression is not just sadness, right? Depression for a physician is a lot of other things as well. And it's actually kind of specific. So you see on this list a number of symptoms of depression, like a depressed mood or even irritability I've put there. Less interest or enjoyment in the things that we usually like to do. Changes in our appetite or our weight. Changes in our sleep, so not sleeping well enough or sleeping too much. Feeling very physically restless, or maybe even you notice someone is physically moving slower. Someone that might have low energy or experience a lot of guilt or worthlessness. This I see all the time in my clinic. And you may hear people you love express guilt, right? Like, I don't want my family or my friends to suffer because I'm sick. So that's a real common thing in depression and cancer. Trouble with attention and concentration. And then those recurrent thoughts about death or about maybe even wanting to end one's life. And so on paper, these are the symptoms we think about for depression. As a physician, I'm going to label it as this depression if someone has 5 or more of these symptoms every day or nearly every day for at least 2 weeks. So it's pretty specific. And yet we may also have a mix of these symptoms that don't exactly meet this criteria, and we still want to address them. We also see here that to meet the definition of depression as a physician would use it, we have to have impairments in our daily life. So it's not that we're just feeling sad, but our sadness or our low energy or that guilty feeling is making us not be able to do the things that we want or need to do in a typical day. Next. We talked about here how it can be very impairing to be distressed, whether that's depression or anxiety or trouble sleeping. So it may make it harder to do those daily activities. Right? I see a lot of people who their depression kind of looks like maybe they don't want to get out of bed as much. Maybe they're not getting their makeup on in the morning or taking their shower, or they're staying in their jammies longer, right? It may be that people are having a harder time with their responsibilities at work or in school and their classes or in parenting, you know, any of those things that we're responsible for doing in the day. It may be harder, or we may actually start to not do them as well as we did before. Other people might notice. It might make it harder for us to make decisions. We care about this in medicine because that translates to our medical care, right? If we're struggling with making decisions, that may mean that we have a hard time making decisions about our treatments. Or it might mean that it's harder for us to keep up with things like taking a bunch of pills every single day or coming to a lot of appointments. And people with depression and anxiety actually are more likely to miss their medicines or miss appointments. And so we really want to pay attention to this level of impairment and try and help. Next. And distress can also impact those around us, right? So it may be a friend or a family member who's doing caregiving, and maybe someone who's a little more distant. Those people can be impacted too. And we know that when a patient has depression or anxiety, their loved ones, their caregivers, are more likely to have depression or anxiety too. And it goes the other way. So if we have a caregiver who's struggling with their mental health, the patient is also more likely to struggle with their mental health. So we have to think about how everything works with the systems we're in, our family, our friends, our other social networks, and how we can help everybody at one time. Next. And it's important to address this, of course. I can imagine you've already started to hear why that might be, but we want to address distress as early as possible, right? So we can start to make some changes so it doesn't get as bad, so we can really help right away. We want to do it directly. I think with mental health, sometimes we don't talk about it, or people feel embarrassed or ashamed or like it's a secret. And so we talk around it, but we don't always just say, I'm really struggling and let's figure out how to get through this. And I also think we need to be kind of aggressive in the way that we address people's distress. We want to make sure that we're coming up with a plan and we're following through on it so that we can really make change. Next. So mental health care really starts with a good assessment. So I see a fair number of patients who would probably prefer to not spend a whole hour telling me about every detail of their life. But it's so important that we get a lot of information because lots and lots of things contribute to our emotional well-being, right? So I'm going to ask Alana to not go to the next slide for a second, but what you're going to see is one time I was preparing for a talk about survivorship, and one of the things they asked me to talk about was like all the things that contribute to our emotional well-being. So I thought I'd make this little picture, and I started putting things on there that contribute, and I ended up with this next slide. You can show it, Alana. So a ton of things contribute to our emotional well-being, right? And I could have kept going, except that I was just out of space, right? So when we meet with people as mental health providers, we're trying to get a picture of a lot of this stuff in a short amount of time so we can figure out what we can help with. And some of these things are things that we have no control over, right? They're like innate parts of who we are. So maybe gender or some personality traits that we're born with that really are inherent to who we are, or maybe some of the genetics, right? There are actually things about our genes that determine a lot about our emotional well-being. Then there are also lots of things that we have control over and we can target. So as providers, that's what we're really thinking about. And I think as caregivers, that's also something we should think about. Or what are these things that contribute to our emotional well-being that we have some ability to change or improve in little steps? And so we'll talk a little bit about that. But I think it's really important to understand that all of this stuff goes together to improve our emotional well-being. Okay, next. So with treatments, what we're often talking about is a combination of lots of things, right? So often when people think about psychiatrists like myself, they're thinking about medications, and that may be a part of things. It doesn't have to be though. I see a lot of people who have depression or anxiety or insomnia, and they aren't that excited about taking a medication. And that's okay, because we can work on how there might be other things we can do to target those symptoms. So for example, we might try some psychotherapy. Now, I use the word psycho because this is the official term. I know some people don't like that term, but this is really just talk therapy, right? That's what it means. It refers to psychology. And so for a lot of people, talk therapy can be really helpful. And talk therapy can be a lot of different things, right? So there are lots of different kinds of formal therapy where a therapist is going to use different kinds of approaches for how they do their assessment and what the treatment looks like. Some therapy is really passive, right? It's a lot of listening, and where the person who goes is doing the talking and the therapist mostly listens and doesn't give a lot of direction necessarily. And then there's also kinds of therapy on the opposite side where there's a lot of action, right? There's a lot of doing things in the session and maybe even having some homework on things to work on and worksheets to fill out and things to do between appointments. And then there's lots of stuff in between. And different kinds of therapy might help with different kinds of problems. So I say all of that because I think a lot of the time I see people who have said, I've tried therapy and it hasn't helped, or I know someone who's done therapy and that doesn't sound like it's for me. But this is part of why we do these assessments, is to see if there's a certain kind of talk therapy that might be helpful for a certain person. And we can try and get people hooked up to the right kind that's going to help with the problem we have. For peer supports, what the research actually shows is, in a lot of cases, peer support is the most important thing in helping with cancer-related distress. So that could be groups. We have support groups here. We have support groups with some of our nonprofits in the community, where people get together in a group with some kind of facilitator and talk about different topics. And sometimes that's kind of prescriptive. They say, here's what we're going to talk about today. Or it might be that you just come and you choose to discuss something or not. Also, you can go and you don't have to share about yourself that first visit. If you want to listen and learn from other people without having to share all of your details, you are allowed to do that. That's perfectly acceptable. There's also one-on-one supports. So you may have heard about our Fourth Angel program. There are a number of other organizations that have peer supports, like the Leukemia and Lymphoma Society, and lots of kind of cancer-specific groups that do this, where you get set up with someone else who's had a similar kind of cancer as you, and you can share over the phone or in person if you'd like about your experiences, and have someone that's maybe had some similarities in what they've gone through. And then we as physicians often are helping people to focus on things like optimizing our nutrition, how much exercise we're getting, how good our sleep is. And this is actually, I think, surprising to some patients, that I spend most probably of my appointments working on these things. When we're talking about things like fatigue or pain or nausea, sometimes nutrition is the most important thing that we can do. And when we get good fuel to our brain through nutrients, often our mental health gets better too. And exercise is another example. We often work with our colleagues in physical therapy or exercise physiologists, or some of our local trainers, to help put together a little bit of an exercise plan, because we know exercise helps with fatigue and nausea and pain and depression and anxiety and trouble with attention and focus, like chemo brain. It helps with pretty much everything is the moral. And then sleep. When we don't sleep well, our mental health is worse. And a lot of the times, depression and anxiety make our sleep worse, right? It's hard to turn the brain off at night. We start to think, and then we're staying awake and we can't get back to bed again. And then the other part is really addressing the needs of our caregivers. Earlier, I said, right, that when we have caregivers who are distressed, we're more likely to have patients who are distressed. And when we have patients who are distressed, we're more likely to have caregivers who are distressed. So we need to help work with everybody to come up with a plan that's going to be kind of sustainable, and everyone can support each other. Next, Alana. So I put a slide in here about sort of various kinds of people who provide mental health care. Because I think sometimes people aren't aware of all the places you can go. So often mental health care starts with our primary care providers, right? So if you have one of those in the community, a lot of the time they feel very comfortable managing depression, anxiety, sleep problems, or at least trying for the first couple things, and then they refer to specialists once they feel like they need some extra help. There are lots of community mental health teams, and so you've probably seen them as you drive around your own communities. And some of our patients work with those teams to help get care. We have community cancer support programs, like the Gathering Place is one here in town that we work with very closely with a lot of our patients. These are programs that are nonprofits that get support to provide all kinds of different programming to our communities, like one-on-one therapy and support groups, and sometimes some nutrition or massage, all sorts of various kinds of things that help with our mental health. We have lots of online support programs, especially since COVID. A number of new virtual programs have popped up. I didn't put a lot of specifics on here because there's so many. And this is something that our teams, our social workers especially, can help to get people set up with. If there's something specific for your case, that would be helpful. I wrote on here that we want to discuss with your oncology team, because I think for a lot of our patients, this is the place we start here. And as a caregiver, this is a great place to bring up concerns as well, talking with the oncology team about what's going on, because they work closely with all of us. And so they can help to get you referred to the right people. And often who they're referring you to first are the social workers. And so we've got two on the line here. But every patient that comes through Taussig has a social worker that works with their oncologist. And these social workers are fabulous, and they're trained to help figure out what services would be most helpful, whether that's kind of more classic mental health care, or it might be working at those other things that lead to distress, like some of the transportation issues and financial stressors and other medical symptoms that are going on. They can help to sort of decide what would be the first step that would be most helpful for you. I also put on here the Taussig Patient Resource Center. So if you have care here at the main campus on our ground floor, we have a health educator who mans the Patient Resource Center. And if you just have a question or are wondering about some kind of support, she's a great first step too in helping with resources that they have there in paper, in person in the center, but also connecting people to other services. And that includes a lot of our integrative medicine programs like art therapy, music therapy, Reiki, the wig boutique, lots of other things that can help to boost our mental health. And then I put us at the bottom. The psycho-oncology team here at Taussig is our kind of formal mental health care. So I'm the current psychiatrist, so I can prescribe some medications if that's indicated for people, and something I do very commonly, of course. And then we have right now a team of 3 psychologists who do talk therapy, like we talked about earlier. And so they're available to work with patients who have cancer. We are hiring more psychologists as we move forward and are really hoping to be able to open up more services to caregivers directly. But now they're really available to help with patients who are struggling. All right, and next. Yep, perfect. So those slides are really just an introduction kind of to mental health, and I think set the stage to talk about